how can we incorporate SLD into policy? How can we make the policymakers realise it's important to integrate, that it's important to pay for it and to get it accessed? So we have two speakers who are going to look at different aspects of this. We're going to hear from Jeffrey Lazarus, who's going to talk about policy readiness related to the Lancet Europe paper 2. Of course, Jeff's an author of that. And then we're going to be hearing from Luis Antonio Diaz, who's assistant professor and a researcher of at the Mazel D Research Center, University of California, San Diego, but also just recently back to Chile for him at the Pontificia University Católica de Chile. And he's going to look at alcohol policies around the world. So, Jeffrey, if you could take the podium. You've got your presentation first of all, and then we'll move on to Luis. Thank you.
Great. Thanks so much, Jackie. Let's see if the advancer is working. It is. So I will look at steatotic liver disease as a public health threat at the crossroads of metabolic multimorbidity. Why do we call it a public health threat? That's language borrowed from the World Health Organization. They used that in 2016 when talking about viral hepatitis. Back then, we had these academic jokes in public health. We said, we don't know what they mean by public health, but then they came out with a monitoring framework. So we're putting it out to WHO and others by saying, this is a public health threat. Now we need to figure out what to do about it, how to monitor it, and the resolution was an incredible step in the right direction. So we've already heard about the importance of a World Health Assembly resolution, giving us that top-down impulse, that guidance, that push of what we need to do. Now we need to work from the bottom up and together with countries to develop national plans. So last week, the member states of the World Health Assembly unanimously approved the first WHA resolution on steatotic liver disease. This followed a massive advocacy effort. We said, some people say, well, we're already doing things that are helpful for MASLD and MASH, and we said we really need to name it to act on it. In order to act on it, people who have, for example, diabetes, as we discussed this morning, need to know they shouldn't be drinking alcohol if they have fibrosis, for example. Many liver societies, but also others like the International Diabetes Federation, the World Obesity Federation, the NCD Alliance, all who have representatives here, joined that effort to bring the resolution into the liver health, bring the liver health resolution into the NCD mainstream, to start thinking about this in the context of universal health coverage, and then a massive global effort to get signatures and endorsers of a global position statement that Dr. Hassani said was really helpful in getting member states to realize there was a groundswell of support for this resolution. Now we need to start figuring out what the next steps are. As a part of that process, the 5 organizations that form the Healthy Liver, Healthy Lives Coalition, ASLD, Apostle, Ale, Solda, EASL, where I used to co-chair, worked together to raise awareness and to work with member states. So 6 years ago, we took a look at, well, where are we in terms of policies that can facilitate addressing what was then NAFLD, NASH. This will be the last time I hopefully ever present this slide. We are in the process of updating it. But back then we found that none of the 122 countries that were surveyed were found to be well prepared to address MASLD. I know there are people from India and the UK who are in the audience. They were the top scorers. Neither of them scored more than 45 out of 100. If they had been going to medical school, they would have failed out, but congratulations, at least you were 1 and 2, because a third of the countries scored 0 on that index. Now we're reaching out to over 175 countries to update that index and see how are we doing in terms of having the policies in place, in addition to the resolution, to address steatotic liver disease. The MASH Cities initiative that I've briefly mentioned is another way we can address steatotic liver disease. Bring it home, bring it to your context. Does your city, does your state region have a strategy. I also work in New York City. We have the Healthy NYC strategy about extending life expectancy to 83 for all New Yorkers. It addresses diabetes, hepatitis C, and many other conditions. Steatotic liver disease is not there. So Dr. Mina Bansal from Mount Sinai and I and others brought city leaders and experts, including community representatives, together to talk about why that city, the largest health system or non-federal health system in the US, should also be addressing steatotic liver disease. So there are things you can do at the local level as well, writing op-eds, engaging with your city leaders, and we launched the first declaration on MASH cities in Bergamo. Dr. Trent White from my team led that effort, and it was great to see the mayor come out and make a commitment to addressing steatotic liver disease. We've already mentioned the series many times, but what we found in the paper on policies was low policy readiness and low systems preparedness and limited guideline integration. Europe remains poorly prepared to address MASH despite its high and growing economic burden. We carried out a meta-analysis and found what some other meta-analyses have found, but with even newer data, that about a third of the adult population in the EU and the UK are estimated to be living with MASLD, and that innovation requires policy adaptation, or Europe is going to be left behind or further left behind because most of those 30% are not diagnosed. And when we surveyed in small populations, most people had never even heard of MASLD, and that included 10% of general practitioners. And again, here's the image we drew to facilitate. We often talk about expanding the SLD community of practice beyond liver specialists as a part of improving policy readiness. So here you can see we need to engage more with associated NGOs. Again, that's why it's great to have diabetes, obesity, NCD, and other NGOs in the room. Industry going beyond pharmaceutical and diagnostics companies, a range of community groups, not just those living with liver disease, but also diabetes, obesity, and other related comorbidities, expanding the research community, and thinking of healthcare providers beyond the liver specialists. And we published this, and it was mentioned on the cover of Hepatology, the AASLD journal, just 3 years ago. We actually didn't even include endocrinologists. Now you can see so many endocrinologists are in the room. I guess because Ken wasn't a co-author, we didn't think of any endocrinologists. I heard that, Ken. We didn't include obesity management specialists, like Holly Lofton was saying earlier, are so important. We didn't include social scientists, which is my original training, and we didn't include labs, which can play such an important role. In an earlier interview, one of the journalists asked me, well, primary care will be overwhelmed, and I said, how about automated reflex testing in the labs, and then the information just comes back to primary care in systems that can do that. And across Europe, we're able to do that, but we don't do that. But this is also just to show a little bit of self-criticism of how far we've come in just 3 years in expanding our community of practice. And it would be interesting each year to see if we can add more to this list. I mentioned earlier that at last year's think tank, we set a range of priorities for 2027, recognition as an essential foundation for action. I think we've achieved that at the global level, but guess what? Most people in the world have never heard of the World Health Assembly. Most clinicians don't know about WHA, so we need to get recognition trickling down, but at a really faster rate to our policy and decision makers at all levels. Collaboration, that expanding the community of practice. This goes beyond the hepatology community, and we need to collaborate with all of the others, and we've already been talking about what those models of care can look like. And finally, implementation. Sounds obvious, but we've also heard, and we all know where there are policies in place, they're not always well implemented. And innovation, I mean, we heard from Naeem El-Khoury and others, we are getting newer and better diagnostics, but we need even more accurate diagnostics. It shouldn't stop us from using the ones we have, but we can do better, and we'll also be doing better with our treatment and care as well. So the Sustainable Development Goals, which Dr. John Silas mentioned, a few years ago, working with the Institute for Health Metrics and Evaluation, IHME, who runs the GBD studies, we created the NAFLD SDG score so we could see around the world with pretty accurate data how well countries are doing, and that tracked pretty much to income level, with wealthier countries doing better in addressing NAFLD, but none doing particularly well. In the Lancet paper that came out today, we did start the policy roadmap. In it, and thankfully the resolution passed because this had already gone to press, we said that the resolution would pass, and otherwise we'd be doing a retraction. So on the left there you see World Health Assembly passes a resolution. Earlier the WHO Executive Board unanimously passed it, but now we need WHO to develop technical guidance, and where they have technical guidance like the best buys and the quick buys, they need to include steatotic liver disease in those documents. We need the European Parliament and Commission and whatever similar bodies you have where you live to be addressing this. So when the new European Healthy Hearts policy came into play, we said you need to include MASLD-MASH. It's still not on their agenda, and most national governments aren't addressing this. So this is what it would look like in the next year, getting regional bodies, national bodies addressing this. In 2027, as mentioned, the UN General Assembly will address universal health coverage. If we're left out, it will be very challenging to get the budget we need to diagnose and treat everyone with steatotic liver diseases. And also we need to be thinking beyond 2030. Where do we want to be in 2032? Where do we want to be in 2035? And then build back in the context of the resolution to make sure that that happens. I'd like to see 90% of the population diagnosed and 90% of them treated as soon as possible. I would go for 2030, more realistic. That's something we're going to have to decide. So where do we go from here? Well, we have a strong body of work from which to build, so we need to accelerate our efforts. And again, I do think we can look to that resolution and go to our governments and say, you signed on to this resolution. Although it's non-binding, you signed. So let's get moving here. The growing burden around the world requires policy changes that not only address social determinants, but also structural and commercial determinants, along with primary and secondary prevention and treatment and care. And as mentioned, we need to grow the liver community to engage policymakers, policy influencers, and people with lived experience. That's why I'm so excited to hear the panelists about to join us, and that so many people in the audience this year also have lived experience and can share their experience with us, but that we also have policy influencers and indeed policymakers among us. And again, we need to be thinking globally. That's what the Global Think Tank on Steatotic Liver Disease does, so we can bring a common voice to increase awareness, to increase action, and to engage and work together with WHO and the UN. They don't have experts in-house necessarily on steatotic liver disease. They'll be looking to us. I think we'll hear later from Mark Thurs and others from Imperial about the work they're going to be doing as a new collaborating center on liver disease. But there are many opportunities now for us to engage with WHO and also other agencies of the UN on this issue. So this is what it looks like. Grow the community of practice for steatotic liver disease, bring a united voice to global conversations, and support implementation of the 2026 WHA Resolution on SLD. Thank you very much.
Thank you, Jeff. You're looking scared, but I'm not going. I'm just going to ask you a couple of follow-up questions to that. You said just then about going to policymakers, health ministers, and you said, let's get moving. So what does that actually mean? What's the kind of 2 or 3 non-negotiable things you would want them to do to make this happen?
Well, first, I'd take the easy one, which is start mentioning steatotic liver disease, and in the context of other NCDs, as Dr. Pugliese mentioned, what we call indicator conditions like diabetes, particularly type 2 diabetes, obesity, and include it in those action plans and strategies. That's just adding it in, because many of the things we will do, many of the non-pharmaceutical interventions around diet, alcohol, and physical activity will be the same. So that's the quick win, is to change that and to include it when we're talking. The longer term, we need to facilitate and make it easier. We've heard about the challenges of diagnostics, the lack of tools, the costs. So I think we need to really start diagnosing more people, and we need to treat everyone who's already diagnosed.
Yeah.
I mean, we have hundreds of thousands of people diagnosed already around the world who are not being treated, even in countries where the treatments have been approved.
And just to follow up on, we talked about the third of people, and you said many of them in that talk, many of them are undiagnosed currently. I mean, I know scientists don't like guesstimating, but I'm thinking back to the days of diabetes when, often Diabetes UK would say we've got 3 million people with diabetes in the UK and 2 million of those don't know. I mean, what's your best guess on proportions of what percentage don't know of that 30%?
Well, people in the front row or anyone else are welcome to yell out numbers, but I mean, I think in many settings, 70%, right. 80%.
Yeah.
I mean, do I hear 90%? I mean, who are undiagnosed?
Yeah. Okay.
People, we don't. In some settings, when we did an awareness study, fewer than half had even heard of the disease. So that's already half that surely aren't diagnosed.
Sure. Well, look, really sobering statistics. So thank you very much indeed for that,
Thank
Jeff.
You, Jackie.
Thank you very much for your presentation. I now invite Luis Antonio to come up and to give his talk about alcohol policies and who's doing it well, who's doing not so well. Thank you.
Thank you for the invitation. I would like to start speaking about public health policies on alcohol with a brief summary of what's the real problem of steatotic liver disease. And the first aspect is the fact that 59% of the populations live with overweight or obesity and 11% with diabetes. But also is estimated that among current drinkers, the estimated alcohol intake is 27 grams a day. That equals to around 2 standard drinks a day in the average population that drinks. And also 7% of the population already have an alcohol use disorder, and that's basically an addiction to alcohol. And this is a huge problem because the prevalence of risk factors for steatotic liver disease is very high in the cardiometabolic risk factor corner, but also in terms of alcohol use. And we know that those risk factors interact in at least an additive way. Some researchers even hypothesize that they can be or interact in a synergistic way. And those risk factors also interact with the genetic background, that it's very important, especially in some regions like Latin America. And this is an example of how the risk factors interact. And this is data from the UK Biobank, and you can see that individuals with excessive drinking, obesity, and genetic variant for risk or major risk, this is a gene called PNPL3. These individuals have a risk of cirrhosis estimated at 8% at 10 years follow-up. But if you take one of those risks, for example, the genetic risk, the development of cirrhosis over time drops to 2%. And this is pretty consistent in the different combinations of risk factors. That's why it's so important to tackle obesity, diabetes, or excessive alcohol intake, even if we cannot change our genetic background. And other important message, at least as a hepatologist, is the fact that liver fibrosis is probably one of the most important things. Because if you have a significant or even advanced fibrosis, you're at a higher risk of mortality due to a liver disease. So we need to prevent the development of steatotic liver disease, but also the development of scars in the liver. And we know that diabetes and obesity are leading risk factors for scars, but alcohol use is even more powerful, generating scars in the liver. In this setting, where we are seated now, we observe that the prevalence of risk factors is very high. The prevalence of steatotic liver disease is high in the global population. And as Jeff mentioned before, there's no many direct public health policies to overcome this epidemic, at least in the muscle D side. But what's happening in the alcohol side? Well, this is a study that we published 2 years ago, and it's basically an index that we create to model the impact of alcohol-related public health policies in the burden of alcohol-associated liver disease. So it's important to notice that this is not a perfect index, but try to summarize the different public health policies on alcohol across the different countries globally. And you can see that in the different regions of the world, we have a very heterogeneous implementation of public health policies, being higher in Europe and lower in the Africa region. The previous data came from 2010, but we also run new analysis up to 2019. And we observed that most of the countries have an increase in the establishment of public health policies. But this is not very, very nice or very good news, because it's not the same, the establishment of public health policies, than the implementation of public health policies. So much countries have policies on alcohol in the paper, but the implementation is scarce in most of countries. And unfortunately, we don't have very nice tools to assess the implementation of public health policies, and probably that's one of the major gaps of knowledge for the following years. But something that's very important from this study is the fact that countries that have a higher preparedness on alcohol-related policy, they have a strong decrease in alcohol-associated liver disease mortality over time. And this is also consistent with the mortality in all causes of cirrhosis. We also have information about combining public health policies, and this is a very interesting study developed in Europe, showing how the interaction of public health policies on obesity, but also policies targeting the affordability of alcohol, can also impact in the burden of steatotic liver disease. And this figure has been adapted from the series manuscript that we published in the alcohol policy. And probably most of the traditional policies, like those reducing affordability and restriction to the alcohol access, and many others, are very important. But from the clinical side, or the liver clinic side, the models of care are really important, especially when we talk about an addiction like alcohol use disorder and alcohol-associated liver disease. And that's why it's so important to work with endocrinologists, primary care physicians, psychiatrists, and specialists on addiction, and many other important healthcare providers to not only treat these chronic conditions, but also prevent the progression and complications over time. And there are some manuscripts showing that these kinds of models, more integrative models, have benefits in terms of reduction in the cardiometabolic risk factors over time, but also reduction in fibrosis and alcohol intake as well. And there's no perfect recipe about what we need to do to decrease the steatotic liver disease burden. But I think this is probably a relevant summary that we need to consider. And the first aspect is that we need to advocate for comprehensive policies on alcohol, but also in cardiometabolic risk factors like obesity, diabetes, healthy food, and also the tobacco policies, because we don't have to forget that smoking is a risk factor for progression of steatotic liver disease to cirrhosis and also hepatocellular carcinoma. We also need to support the community and advocate for non-stigmatizing language. And for sure, we need to work at the schools of medicine. See, it's very important to teach how we need to estimate alcohol intake in clinical practice. All physicians need to estimate alcohol intake, or at least ask about alcohol. Even if you're going to the emergency room, I'm 100% sure that some of those consults are related to alcohol intake. Same for the endocrinologist clinical practice. I don't envision the management of steatotic liver disease in people with diabetes without asking about alcohol, because even if you have MASLD or MET-ALD in someone with diabetes, alcohol is an extremely important risk factor for progression, and this is something that we will see in the next section. We need to invest more money in research in steatotic liver disease and public health policies, but also we need to tailor and create models of care affordable and probably tailor for different areas of the world. And finally, we know that non-pharmacological treatment in steatotic liver disease, including the stop of alcohol use, is very important, but we also need to develop more research in MET-ALD and ALD, especially in the area of the new medications in MASLD. So I think this is what I want to present now, and thanks for your attention. I'll be looking forward to your questions.
Thank you very much indeed, Louise. So obviously there's a lot of kind of semi-bad news there about the challenge, but I think there have been some examples of good practice. I think Lithuania has managed to implement and had success. Can you just tell us briefly what's been happening there?
Of course. We didn't have a lot of time to show specific examples, but Lithuania is a very nice example of what is a successful implementation of public health policies on alcohol. In the last around 17 years, Lithuania have established different policies to restrict the access to alcohol, to increase the minimum age to drink from 18 to 20, and restrict.
Was there a pushback from young people on that, or did society in Lithuania accept it?
Well, at least was published. This was accepted, and not only accepted, the impact that had was very important, and the estimations show that the alcohol or average consumption of alcohol decreases in 1 liter of pure alcohol per capita after all the implementation of public health policies per year.
Right.
Yeah, per person.
That's significant, isn't it?
Yes, and there are other important examples like countries or areas with minimum unit pricing, and Lithuania show that you can decrease the alcohol intake, but also reduce mortality related to alcohol, in also areas like Scotland and other areas with minimum unit pricing. There's evidence showing a reduction in mortality. So for sure, some people will feel bad about restrictions, but down the road, the impact in the overall society is so high in terms of burden and mortality.
Yeah, and just briefly, in terms of reaching vulnerable groups, people hard to reach who don't necessarily won't go to primary care or won't go to, maybe, as you say, go A&E, but it's not even measured. So how can those groups be reached from your perspective?
Oh, sorry.
How can vulnerable groups, maybe people who drink too much and we just, we only find out they're drinking too much at A&E, how can they be reached beforehand? I know that's not your sphere per se, but do you have any thoughts on that?
Yes, that's a very important aspect, because it's very demonstrated that people that start drinking in earlier stages of their lives will remain drinking, and probably those who heavily drink as a teenager are at higher risk of alcohol use disorder. I think we need to screen or perform a universal screening for alcohol use disorder. There's
at what age, or when would that happen?
In any healthcare access because you can do it with one single question, with 3 questions, or 10 questions. It's up to you, whatever you want to use. But it's important to notice that more than 200 diseases are related to alcohol, not only liver disease. That's why it's very, very important to screen for alcohol use disorder.
Okay. That's really helpful. Thank you very much indeed, Louise.
Thanks for the invitation.
Let's give him a round of applause. So I want to welcome my panel up. We've got a great panel for you. We have Nikos Dedes, who is the chair of the Greek Patients Association and chair of Positive Voice. the Greek Association of People Living with HIV, so thank you and welcome to you. Kush Baseskera, who's a hepatologist in my local area, in the Bristol Royal Infirmary in the UK. He's a consultant senior lecturer in liver disease epidemiology at the University of Bristol as well, so welcome to you, Kush. We have Hema Frubeck. Did I say that correctly? Hema. Endocrinologist, obesity area, Department of Endocrinology and Nutrition, University of Navarra Clinic in Spain. So thank you, welcome to you. And Jose Ignacio Ecanis. Where's Jose? Ah, there you are. Please do sit down, you're ahead of me. So much to cover on this, but just quickly, what's your response to what you've heard so far? Kush, I'll go to you first. I mean, it's, just hearing what...
Yeah, I mean, it's a really exciting time for hepatology to have steatotic liver disease prioritised like this, to be able to go to people that commission services and illustrate that this at an international level is really important, because we know that steatotic liver disease is something that disproportionately impacts people from underserved communities. And then just, I have to say, we're seeing Lewis's slide on about England not being as, about the UK not being as prepared as it should be, was disappointing for us, but it's just a reminder that we can't rest on our laurels, and seeing all the great work Lithuania has done has been amazing.
Yeah, okay, excellent. All right, well, look, let me come to this side of the room. Nikos, what did you take from what you've heard so far?
Yeah, well, I agree, it's exciting, but I would say not for hepatologists, for all of us. I think that's the clear message that actually the resolution makes, is how this is a nexus which we have to recognize that is there, because of course we've heard that this is the first problem, the awareness, the understanding. I mean, I was thinking, it wasn't mentioned from the speakers, but we have a problem of recognizing this among people with a condition already. So it is work for us, based on the organizations, but then again across all specialists, and then to the policy front.
Okay, thank you. I'll come to you, Hema. What about you? What are your instant responses to what you've heard? Any comments or anything that resonates with you particularly?
Yeah, well, the first thing I have to say is I'm absolutely thrilled to be here. So to be learning from each other, to share perspectives, it's much better when you try to join forces, because if we continue working on our silos, we're not going to progress. So this initiative, like Jeff's is driving forward, they're really so helpful, not only for the patients, but also for ourselves as professionals, healthcare professionals.
Thank you. Now, Jose, you come from a policy and political background, but so we know that you're not a liver expert. But what did you take that was interesting in what you heard?
Well, firstly, thank you to the Institute for Global Health and the Public Health Lever Group for having us, for the great job they are doing. I'm not an expert hepatologist, but I also worked for some years to include new policies and new innovations in health system. I'm learning a lot of today.
Yeah, I think I saw you there, and I didn't actually spell out who you are. Former Minister of Health of Madrid, former health spokesperson in the National Parliament of Spain. So there we are. That's why I meant that background. So thank you for joining us. Now, I want to, we've got these questions up behind me, which I can't see, but I want to ask Kush first of all. You told me that this question, this first question, why does steatotic liver disease need to be part of NTD action plans and strategies? Why does this matter to clinicians? And you said, Jackie, I've got an emotional response to this. And I said, what do you mean, Kush? And so tell me what you mean by that.
Well, so the reality is steatotic liver disease is overwhelming the leading cause of liver-related mortality and morbidity in Europe. So in the UK, it's one of the leading causes of death in working life. So in 35 to 49-year-olds, it's overtaken suicide as a major cause of death.
In men?
Overall.
Right.
But it's also a major cause of working life years lost, and a big impact on productivity. So, sorry, I only got UK figures, but so for example, it's second only to breast cancer in women as a major cause of working life years lost. We know that it disproportionately impacts patients in underserved communities. And we don't have the latest figures, but we estimate the vast majority of patients with cirrhosis present at the front door of the hospital as an emergency in liver failure.
And you see that in Bristol, do you?
Yeah, so I mean, all the hepatologists working in Europe will be seeing alcohol and predominantly alcohol meth ALD and some mild sort as well presenting in liver failure, missing years of potentially reversible disease.
Okay, thank you for that. Now, I want to come to Nikos, because obviously, when we did it was, Jorn did the standing up, and that was really impressive, and of course, it's really great that we have patient representatives now. And again, you're not a liver expert per se, but I just wanted to know, from your perspective as a patient advocacy person, what are the barriers that you think people living with steatotic liver disease may face when trying to navigate this health system? We've heard of the fact that it treats people in silos, but what would it mean to people if we had an integrated system, and how might it better improve picking up cases?
I mean, everybody mentioned that the starting point is this fragmentation of care when it comes, to all conditions and comorbidities, but particularly for the SLD. Actually, the think tank contributed to me recognizing that I was a muscle T patient myself, and through the use of incretins, I have reversed that. So,
congratulations.
Obviously, we're talking here about people who would also live with diabetes, with cardiovascular risks, and all of these things that we've discussed. So the second problem, of course, is that we face in this, as in many other diseases, delayed diagnosis. And contributor to that is the stigma and the blame which is associated with liver conditions.
Yeah.
And of course, it's not just the liver condition. This blame is carried over even to the treatment that we have today. So it's all of these things that contribute to this situation of this fragmentation. And where do you begin?
The HIV community really successfully reduced stigma and really kind of were very, as I say, positive with using that word is ironic, but they were, positive in challenging people's negative assumptions. Mm-hmm. How do you think in this situation, people with, a condition which used to be called fatty liver disease, and we know that it's changed because of the concerns over what that sounds like, how do you think patients can reduce stigma and persuade others to?
Well, I think it's, first of all, where we go back with Jeff is exactly working together in addressing and making clear to policymakers that in order to treat a condition, you need also to understand the drivers, both of the vulnerability, the delayed diagnosis, the problem to care delivery. This is something that we can jointly do going forward. The other thing is, of course, to make sure that, and this is why this resolution is fantastic, because now it integrates SLD within the NCD architecture. And where patient organizations can contribute is making sure that this integration takes place. Jeff mentioned the need of mentioning it,
yes.
Including it into strategies.
Yes.
And this is where we need to work together, both interdisciplinary, but also across sectors.
Let me bring in Hema. Nikos mentions the drivers of SLD, and I wonder, how do the current European guidelines, the treatment for obesity guidelines and the clinical pathways, where are the gaps in these on the referrals for liver disease? How can we plug those gaps?
Do you mind if I go a little bit further and add to
please
the
do.
Emotional response of
Yes,
Kushman,
please do,
also
absolutely.
scientific one?
Yeah.
Because I believe, which is something very evident in medicine, if you don't look to identify something, you need to look for it. Mm-mm. So if you don't look at the liver and you don't screen for steatotic liver disease, you're not going to find it. So that's something that we need to do. And this is especially important because in most cases it's such a silent disease. Mm-hmm. So it will go unnoticed for so many years. We heard before liver enzymes will be normal unless it really progresses to an end organ stage. So it's important, the earlier we intervene, the better. Coming back to your other question.
Yeah, are they in the guidelines and
So
how can we get them in there?
We had the European Congress on Obesity 2 weeks ago in Istanbul. The liver, I can tell you, was one of the main protagonists of the Congress.
That's excellent news.
We had packed full sessions. Everybody was aware of the importance of the liver.
And where did that push come from?
I think because we did common guidelines, so ESL was really one of the pioneers in putting together societies, the Diabetes Society, the Obesity Society, the liver community, to do things together.
So they are talking to each other.
Yeah, talking to each other. So in that sense, it's so important because obviously hepatologists look at the liver, the cardiologist looks at the heart, but in endocrinology, and especially in obesity too, we are used to looking at all organs. So we have a very holistic approach. So we look not only at the liver, we look at the pancreas, we look at the muscle, we look at the heart, we look at the bone. And then we are very much used to being multidisciplinary, so to learn from each other.
Sure.
So I believe that's an important point. It is fair to say that we are clinically mature, at least in the obesity community, but it's also fair to say that probably there is a policy fragmented approach, as Nikos was saying. And there is a lack of policy integration in spite of very clear epidemiological evidence that would
and so what do you, just briefly, because I'll come to her, over here, but briefly, what can change that policy fragmentation?
I think patients are really powerful.
Yeah.
So in obesity, we are still carrying a lot of stigma. I get very cross when some drugs are being reimbursed if you have type 2 diabetes. But if you have only obesity, you're not being reimbursed.
Yeah.
What's more stigmatizing than that?
Yes.
So we've been blaming the individual.
Interesting.
Saying, oh, you're not having a proper nutrition, you're not exercising enough. No, come on. That's not true. You're ignoring a lot of science, neurobiology of energy homeostasis.
That's interesting, because I was having a conversation with Holly yesterday about this same issue. That does, everyone's singing from the same hymn sheet. It seems to me that when we're doing his list of people who are standing up, the medical societies then, the other medical societies, having representations from them would be a good addition next year for the flagship event. Let me come to Jose. Jose, you're a former health minister, as I said. You've got multiple disease areas and clinicians and advocates banging on your door saying, ours is the most important. How can we change this? What are the challenges at your high level in promoting policy change and integrating new policies into practice?
Well, most of healthcare systems need reforms at the moment to adapt to new realities, especially chronic disease or the shortage of resources or professionals and governance. I have been with Alan Milburn, the former UK
minister. I love Alan Milburn.
And we are talking 2 weeks ago in Madrid about reforms in UK and Spain. And he's
a good guy.
And it's very important to take advantages of these reforms to introduce policy changes. So in my opinion, SLD is a clear example that has special characteristics that require to be addressed in a special way. Why? Because there's a significant impact on the population, because it's accompanied by other metabolic diseases or elements that type to the diabetes mellitus or obesity or high blood pressure or cardiovascular diseases or chronic kidney diseases. But the main thing is that it can be prevented.
Yes.
And that policy is very important to where to put the money.
The UK certainly is trying to put a better emphasis on prevention, but they've been saying it for years and years, haven't they?
Yeah, quite a while.
And I think also community, work in the community too. But I think that obviously, like all European countries, Jose, we've got pressure of finances, haven't we? We've got the geopolitical environment, and it's a difficult scenario. And, you know, the finance ministers are not going to be keen on giving health, you know, lots more money. So that's a challenge, I'm presuming.
Yes. So can be prevented and can be reversed.
Yes, and that saves money. And that's the way, that's the thing to get across.
The prevalence is increasing around the world. The increase of the burden is very worried about. And there is under-diagnostic and a low acknowledgement in the social, political, and professional level.
Let's move on to some solutions, because I want to have a positive note, right? It's not all negative. Kush, you know, I wonder, you know, Louise was saying he thinks that every kind of interaction, certainly in secondary care, there should be the alcohol, kind of maybe an audit C or something, some level, so we get an idea of what's going on, and also maybe, you know, we've talked earlier about FIB4 for, you know, at-risk and indicated condition patients. And also, I wanted to talk to you about how we find these vulnerable patients. You know, so what's in your view, the solutions going forward that are the no-brainers?
So, I mean, the no-brainers, in the first instance, we've heard earlier from this day the importance of having community diagnostic pathway that are just embedded in the first instance, and collaborating with primary care to make sure that it's easy for primary care feel it works for them on their patch. So that's the base case. Then the next step is how do we take testing that is often delivered in secondary care and move it out into the community. And you were talking to Louise about patients that don't access care in the standard ways that we would think patients would. And so we've done that, and we're doing that across the UK with NHS-funded pilots. So, for example, we've tasked hepatology nurses to go to community detox centres, to go to hostels where people experience homelessness would be, and to screen people with clear risk factors. The other place we
and sorry, how has that gone down with those people?
Yeah, so the patients, the interviews we've done with them is they really value it. I don't think we appreciate necessarily. Well, I'm preaching to the converted, but generally clinicians don't appreciate how difficult it is for a patient to come to secondary care to see you. You know, whether it's the parking, it's getting the childcare. It's actually they're just really scared about coming to the hospital because they had a bad experience. So moving,
and that's non-chaotic patients. That's ordinary patients, right?
So, and what we have found is that proactive, focused testing in high-risk groups has a higher yield for identifying clinically significant liver disease.
Yeah, and just one more point before I move on to somebody else is that, again, reflex testing. Louise mentioned it. It's something that I wasn't aware of before I came in today. Can you just explain to me what it is and why it's helping briefly for people who don't know about it?
Yeah, so reflex testing...
Again, this seems also a no-brainer to me.
Yeah, so for example, if you have a FIB4 blood test, a lot of labs will be able to, if that test is elevated, automatically send another blood test called, for you most commonly enhanced liver fibrosis test, to give 2 fibrosis assessments for someone. Not all labs do it. I'm conscious that John Dillon, the creator of the Intelligent Liver Fibrosis Test, is in the building, and he's done this to the nth degree and with great success in Scotland. But it's shown to be cost effective in Scotland to do reflex testing in that way.
Yeah. Okay. Thank you. Hema, we were hearing yesterday at the media meeting about Jeff's trial in New York, which is involving giving healthy meals as part of medications to help people, because we all know that healthy eating messages, it can be very difficult to take on board. And I wondered how you felt that these messages could be implemented more effectively for young people. How are the barriers to eating well inexpensively? What do you think could be embedded in policy?
I think that's really important, and education is really a key element here. we need really to transmit nutritional information to school children. So every school child knows what's good for their muscles, for their bones. We need to tell them what's important for their liver and why it is important. So I believe that there is so much to gain if we just incorporate that information already at school age.
And Jose, are there any practical examples from Spain, not necessarily in liver health, but where things have been successful and there's learnings, positive learnings for that?
I was involved in a process that had good results.
Yeah.
In 2014, a new highly effective product for hepatitis C appeared in the market. In Spain, we had a population at that time of 50,000 people eligible for that treatment. The price of the individual treatment was extremely high. Locally, some pressure of the patients and other began, and in our record time, 2 months only, we were able to align the Ministry of Health, the Ministry of Finance, the Treasury, the patients, industry, and a reasonable price reduction was negotiated for this state-of-the-art treatment, and a very significant amount was budgeted in the next 3 years, and more importantly, a strategic plan for the future was designed to address the hepatitis C. So 150,000 people was treated and without very good results.
And cured, okay, well thank you for that. And I think we've heard earlier on from Egypt's perspective, so it's that's a great win for many countries. I'm going to throw it open to the audience, but I do want to go specifically to Mike Dunbier, who's from Movendi International. Now, Mike, you've got a compelling personal story. Can you put your hand up? Are you here still? Yeah, lovely. I just wondered if you could explain, if you don't mind, why you got involved in this work, and from your perspective, how your organisation, Movendi International, is addressing liver disease with an alcohol policy. Is there a mic for Mike? A mic for Mike! Excellent. While we're getting a mic, over there.
Got to say it twice.
Just maybe a minute, Mike, because we're over time, but
Thank you very much. Every time we speak about liver disease, I think about my grandfather, who I never met, who passed away from liver cirrhosis when I was 14, 15 years old, and my mom, who grew up with a father with alcohol addiction, did not want us to meet him. And the work we do, I mean, this is an amazing event. It's really many important things that have been said. For us, it's about 3 things, 3 Ps. People, we provide enabling environments for people with alcohol use disorder who very often have other conditions, like was said, including liver conditions. And we provide that environment for children and young people who grow up in these environments and also need support. The second P is practice. In Germany, we joke, when does a person get diagnosed with an alcohol use disorder? When the person consumes more alcohol than the doctor. and it's tragic because we have the stigma also in the medical profession. So the practice work that we do is a lot empowering the medical profession to have these conversations, like Luis was saying. And we need policy. That's the third P. For us, alcohol taxation is really important because we need to generate the resources for the healthcare system to actually build out a self-sustaining system where liver disease treatment is part as well.
Yeah. Thank you so much, Mike. I really appreciate you that. Yeah, I've got a heap of questions. So I've got a question here and then a question over there. All right then. Okay, the mic's closest. I'm sorry. There we go. Can we get a mic over here as well, please, so we can get it for the second question?
I have a comment and a question, and it is related to Jeff's presentation in the question 3. So, Jeff, can we think of adding radiologists and imaging professionals bringing to the group? Because that will a lot of people, they go for the ultrasound and the other imaging, not for the liver-related issues. And one of the most common report is you get fatty liver grade 1 or grade 2. Can we think of changing this to steatotic liver? And this is happening in the nephrology space because they report nephrology as increased renal echogenicity, needs further correlation, clinical correlation or further investigation, but nothing is done from the radiology side on the liver side. So they simply report fatty liver grade 1 or grade 2. Can it be followed by, can we pursue these societies to write steatotic liver needs further correlation, needs further investigation to find out, rule out liver fibrosis?
Jeff's looking quite gobsmacked.
I would say that
yeah.
it should trigger, if someone's got steatosis on their ultrasound, they should have fibrosis restratification and clarification of what is causing that. And I believe majority of clinical guidelines do have that, but it's not automated necessarily. It's certainly not in the UK.
Yeah, thank you. I've got heaps of questions. We've only got a short amount of time, so let's come to the lady here.
Hi. So I wanted to just bring up the idea of, if we're talking about, meeting people where they're at, meeting patients where they're at, I think we're remiss to not bring up the social media aspect today. So I'm surprised that hasn't come up before, because I have treated people from the spectrum of the Bronx to the Upper East Side of Manhattan, and even when people have, lower than a 6th grade reading literacy, they all have access to Instagram and TikTok. And I don't know many hepatologists or endocrinologists on social media, but I know a lot of people that are acting like endocrinologists and hepatologists on social media. So I think that's, hopefully next year with this iteration, we can bring some of those people here, the credible ones, to kind of speak to how they actually reach patients.
Yeah.
So I'm curious about how we think that can actually impact policy.
We actually discussed it quite a lot
Okay.
last year for the impact of social media, and I think that obviously it's a necessary tool to increase awareness. Just one thing, if I may, it's also a question and a reflection. Jeff, you mentioned that we should go immediately to our governments because the resolution is there. But our experience shows that if we do not have the technical guidelines coming from WHO, how can we make sure that these, even we put anything on the positive list, either whether it's treatment or diagnostics, and with the health technology assessment scrutiny these days, without the guidelines, I'm not sure. So anyway, it's just for all of us together to make sure that we get this from WHO.
Yeah. Will WHO be at EASL next week? We can harass them then.
And WHO is not at its best right now. So is this an opportunity or is this a hindrance? Can we help?
Yeah, we've got clinical practice guidelines for that are established for MASL, and I'm sure they'll come up for alcohol-related liver disease. We don't have a CPG for steatotic liver disease per se, and that is probably something that needs to be developed. Yeah.
Okay. Let me bring in the lady who's been waiting patiently, and then we've got, at the back.
Hi. I'm Vanessa Hebditch. I'm from the British Liver Trust.
Ooh, Winchester. I was going to start this meeting when I was moderating saying that actually I literally live 5 minutes from the British Liver Trust. There we are. But here we are now. I didn't know you were here. Fantastic.
No, and it's great, I think, that we are talking about alcohol as well as MASLs, because for years and years I came and it was always hepatitis C, and then it was great that MASLs started getting attention. But actually, when you were talking about those figures, Kush, the vast majority are alcohol-related liver disease, and that's the biggest cause of mortality. But I loved your 3 Ps, and for me, lead question number 4 is 3A. Affordability, and we need policy changes in affordability of alcohol. It's accessibility. You can get it at any time, day or night. You can get it delivered to your door without leaving the sofa.
Yeah.
And then it's acceptability. So we need to address that acceptability in the culture. So for me, the policy changes need to be those 3 A's initially, even before we get to liver disease, and that will have the biggest impact.
Okay, thank you. One last question at the back there, and then we'll have to move on. Thank you.
Hi, Chris Kopka. Most of you know me as the person who works with Jeff and Jeff's team in strategy. Many of you also know me when you get to know me that I've been sober since I was 22. And so a quick observation about policy failures, and then to bring it back as a question for the panel. I've been sober for a long time, and it's a socially acceptable phenomenon for people to ask me, why do I not drink? Very rarely will I say, well, why do you drink? And so, but what I'm sharing is the policy failures scale all the way down as a matter of culture of what's norming. And then we zoom all the way up to the level of culture that alcohol features uniquely in virtually every religious tradition in the world. From spiritus, we have the spirit and we have spirits. And so I want to bring back to the panel, as you think, sometimes we frame cultural determinants as a sort of a logic model. But we're also, with alcohol, the opportunity is also the challenge.
Okay.
That what are some of the cultural approaches that you would present for addressing policy failures?
That's a great question. The cultural determinants of health is a new determinant. Right? How do we deal with those? I think because we've had such a wide-ranging discussion. I've got to pull the time. So let me just ask the three of you, I'll ask the two of you, how do we address those cultural determinants? And for Hema and Jose, any final point, just in 30 seconds. How do we address the cultural determinants that everything seems to be, alcohol is completely socially acceptable, and it's, it's stigmatizing to say, oh, why don't you drink?
Well, actually, we have to accept the realities and then make sure that we have, we accept difference. I mean, we need this across all the course. So yes, I mean that's. And if I may say one final thing is that once we achieve political recognition, we have to set measurable targets. We know that if we, like the three ones, there are examples of setting very nice marketing on what kind of targets we're talking about, so in order to reach the various steps of success in the response.
Okay, thank you very much, Nichols. Hema, a final word from you.
Yeah, so I would say we really need to measure things. Because if we are still relying on questionnaires and on self-reporting, it's going to be difficult because there are unconscious things. So I think now we should be screening, and we have a biomarker for alcohol consumption. So if we have the data, it would be easier.
We're going to be talking about that in the next session, which is coming up very soon. So but thank you for that, Hema. Jose, just a short, quiet final word from you. What is your final takeaway message? You can talk about that, yes, if you're... Spain's a good wine producer.
The theory for change, the theory for change is A, B, C, D, E, is awareness, to raise awareness of the problem. The second is B, budget.
Yes.
Without budget is not real support. The third is C. C is cost opportunity.
Yeah.
For me, is if we don't, the consequences will be worse clinically, professionally. Data is D.
Yeah.
The information and evidence are vital, especially in the age of artificial intelligence, and elections.
Yes.
Politicians has a bad habit of wanting to win elections.
Yeah.
So elections are a good time to seek compromise and support.
That's a great advice. Thank you very much indeed for that, Jose. Kush, a final word from you.
Yes, I mean, just thinking about that question, what needs to change by 2030, and related to these two questions, and to what you said there, Jose, I think we need to win the political argument that alcohol-related harm costs far more than any taxes the alcohol industry brings in. Culturally, we should treat it the same as we treated tobacco. And we are ill-equipped, as Milena says, to deal with the advertising or the digital space, and we need to be, have it really flesh out strategically how we will, enforce regulation to prevent advertising to young people, to stop them getting adversely algorithmic advertising.
Great. Okay. Well, there's some really excellent initiatives and points there that we can take forward. And as I say, I'm already looking forward to next year because we've got so much to discuss, haven't we? Thank you very much indeed to the panel. I have to give him a good round of applause, and we could have carried on for a long time. Thank you. So if you could leave your microphones...